right, we're going to go ahead and get started here so as to have a semblance of staying on time. And the title of this section, as I refer to my outline here as Derek came up with this, was, I believe, intraoperative disasters or something? Intraoperative disasters. Okay. We have 3 cases, and I think all of these are really good cases to learn from. So we'll start out with number 1. This is a 67-year-old female. By the way, these were referred into us, so I can't take credit. I've had my share of disasters, but 67-year-old female, right knee pain, BMI of 32, failed non-operative measures, not significant comorbidities, knee range of motion is reasonably good, stable to varus valgus, motor and sensory exams intact distally. Here are the pre-op x-rays. So valgus knee, failed conservative care, reasonable to consider. There's no tricks here, reasonable to consider knee replacement. Anybody have an issue on the panel proceeding with a knee replacement with this patient? Everybody's good? All right. So patient underwent a right total knee, fixed bearing at an outside hospital. Post-op day 1, the knee felt a little unstable, but she was able to get up and PT cleared her to go home, so discharged home on post-operative day number 1. Came back for her 2-week follow-up with the PA and said the knee feels a bit unstable and she's falling more than she thought she ought to be, and she was reassured, continue with physical therapy, things were going to get better. But they did get an x-ray just to make sure nothing was wrong, and alignment looks reasonable. Anybody in the panel see anything that's jumping out here at post-op x-ray 2 weeks down the road? I didn't really see much, to be honest, when I looked at this. So looks okay. And comes back at 4 weeks, is continuing to fall, and the surgeon notes that the patella is not really tracking completely normally, and that something just feels a little off, and surgeon gets an x-ray at this point. And Derek, what do you see here? We're now a month after surgery. Patient is complaining of the knee giving way, instability, falling down.
Yeah, so I mean, it appears that there's something going on with the patella, maybe a little fracture there, maybe the patella is certainly not tracking the way it was before. I'd also be concerned a little bit about the tibia. It's hard to tell from, without the prior film up there for comparison in terms of rotation, but it's possible the tibia is sort of starting to fail. But the patella is clearly not tracking the way that you want it to.
Yeah, okay, I'd agree. It looks like there's something going on, maybe a little fleck of bone or something, and kind of hard to know.
It's a nice AP view on the lateral of the tibia of the patella.
Yeah.
Yeah, exactly. So the surgeon thought, well, something's not right. It must be patellofemoral, and took the patient back to the operating room with the pre-op plan of doing a lateral release and making sure the medial retinaculum was repaired or reconstructed. And when the surgeon got in there, the knee just didn't feel very stable, and it was more than, quote, expected, and so closed it up and sent it up to us to take care of. So we're now about 6 weeks after surgery. Patient's having persistent instability. Here's the exam under anesthesia, and the knee seems to open up a fair amount medially. And when we opened the knee, there'd been a transection of the MCL. Now, maybe it was partial and there was a thread or two hanging on, but clearly the knee is grossly unstable in flexion and full extension. Patella is kind of the least of the issues. So what do you do now? We have a 68-year-old female 6 weeks after a total knee, has an MCL disruption. So what are our options? Stefano, what are you gonna do?
So you said it was the fibers of the MCL still visible? There's still a construct there you could potentially...
No, it kind of looks like a machete went through the medial soft tissue.
So no tissue there to reconstruct. So people have described reconstructions and even using buttons to reattach the medial collateral ligament to the medial side. I have not had the opportunity to do a soft tissue reconstruction of an MCL, taking a graft or anything of that nature. So I haven't had that. I'd have to look that up, to be honest with you. I haven't done it, or refer to one of my colleagues here if they have. Otherwise, the challenge here may be to maybe constrain the tibia. That said, if you cast these folks for 6 to 8 weeks, it's remarkable how much they stiffen up on the medial side. And if you protect it with a thicker post, the problem here is that Conda, I don't think, takes a thicker post. You'd have to revise the femur to get a. No, that was a. Yeah, I don't think there's a tibial insert for that device, which is semi-constrained. So I think you could certainly try stabilizing it, letting it heal. I think I've actually seen that work. Or you might revise the femur and add a semi-constraint. I don't think you have to go to hinge. I think it will eventually tighten up. That's just my take on that.
So, Chance, what do you think? You're going to treat this like a 20-year-old MCL injury. It's got an intact ACL, PCL, and just hinge knee brace should be okay. Put me back in, coach.
Yeah, personally, my approach to this, especially the patient is demonstrating that she's not tolerating the instability well. She's having falls. There's other issues. There's this patellar tracking issue. The tibia is a little bit oversized on the AP. It's on a little bit of varus. This is a knee that if it came into my clinic, and this is a difference between it being my own case and somebody else's case, I'd probably be a little more aggressive. I think I would actually revise the entire construct, and I'd probably go straight to a hinge. I think she's ultimately going to be happier with that. Obviously, there's downside to that. What was the patient's age?
68.
Okay, yeah, so that's a little younger than you'd like to put a hinge knee in, but I think in this case it's probably the best answer for her for the most predictable long-term outcomes and the earliest, functional ability. That's how I'd approach it.
Derek, any allograft options here?
I'm going to disagree with Chance, partially for the sake of disagreement, and to generate that discussion, but also because I think that, as you said, in sort of late 60s and otherwise really healthy person is a pretty extreme thing to do a hinge. Now, I've certainly put in hinges in younger patients than that when we had no choice. But I think we shall remember that a hinge really is kind of a salvage operation for a knee, and that the long-term results for a hinge are not amazing. And so if we put a hinge in her, I think we're almost kind of dooming her to an even harder and more aggressive surgery down the road with even possibly worse outcomes. I think if you're happy with the component position, and I think that if you're happy with the rotation on the tibia and the rotation on the femur, and you're happy with the cement technique and the implant, I don't think necessarily that you have to have a semi-constrained implant if you are able to reconstruct the MCL. And we've done a couple of these cases with our sports surgeons, actually, where they've done an MCL reconstruction with a cadaver graft and given the patient a period of immobilization and recovery, and they've done okay. And there's a couple of studies that look at that, but there also, as to Steph's point, there are a couple of studies that look at just immobilizing these people and how stiff they get and how relatively well they do. So I think if you combine a reconstruction, an MCL reconstruction, with a period of immobilization and progressive motion, I think you might be hopefully potentially saving her from the hinge, or at least delaying the hinge or delaying a larger revision surgery for a longer period of time. And she may not get the motion that you'd want out of your primary total knee. I think that might at least help her with stable walking.
So this is a great case because we have 3 different opinions on how to deal with this, and I'm getting paralyzed by watching that video one more time. I think one of the problems is all of us who've done this in the past and used allografts, and I did this where I'd try and reconstruct an MCL. I mean, part of it's probably my crummy ability to do that operation 20 years ago, and I think our sports medicine colleagues are way better at that now, certainly than I was 20-something years ago. So I think that is a consideration. The only thing is you have to back that up with a more constrained device. And so with this particular knee, you'd have to revise both sides of this knee to put in a more constrained, like a varus valgus constrained implant, which I think if this is a PS knee and just doing an allograft, leaving a PS knee 6 weeks down the road, that's challenging for sure. I think when you have complete MCL disruption and you try and rely on either a PS or even a varus valgus constraint, the track record of that is not good. They tend to fail because, those posts can't withstand complete MCL deficiency. The question of if they'll scab down enough to make it okay if you immobilize them, I don't know. I've never had the courage to try that. So, there clearly wasn't a great option. I would agree with Derek. A hinge is a salvage procedure at best in a 68-year-old who thought they were just coming in to get a total knee replacement. They're going to do just like all their friends down the street do, and suddenly you're 2 operations into it and you have like the end of the road solution. On the other hand, she wasn't the world's most mobile individual, wasn't terribly active, and so we kind of weighed the risk of failure with an allograft with the badness of having a hinge, and ended up with a hinge. So certainly not the solution that you'd want to have as your first choice. And Chance, like you said, it's probably easier to do this if it's not your patient to begin with. They come to you and you go, well, hey, listen, this is the hand we were dealt, and this is how we're going to deal with it. So right or wrong, that's what we did. And I guess treated or weight bearing is tolerated. Fixation's great with these kind of knees. The question is, number one, what do you do if you recognize intraoperatively you've damaged the MCL? Can be with a saw. More often than not, it's using the saw on the medial side to cut your tibia or your posterior medial femoral cut. What do you do if you first of all, you got to recognize it and realize that if you thought you were going to put in a like 5 or 6 millimeter insert and you're suddenly putting in a 14 millimeter insert, something's got to be wrong, and more likely than not, it's the MCL's been disrupted. What do you do if you recognize it? So, Derek?
I think it certainly depends on the degree of disruption. I mean, there's certainly there's the hey, did I catch a few fibers, or is it completely out? And if the MCL is completely out, then I think that it kind of depends on where you are in the case and what you have available. So if you have already cemented in your implants, then I think, given sort of the morbidity of then trying to take out well-fixed implants and the bone loss of that, I think it'd be much more likely to go to at least try a reconstructive option. And if my tibia supported a more constrained polyethylene, then I would go to that. But if I hadn't cemented in components yet, then I would consider, depending on what I had at my hospital, to actually use revision components in addition to some kind of MCL reconstruction. In terms of the chronic disruption management, I think it sort of speaks to the importance of doing a really good physical exam in the office. I think in the era of the electronic medical record, where the EMR serves as the billing physical exam, but we don't actually necessarily do the whole physical exam that the EMR says we do, I think it behooves us to really still continue to do a real physical exam, so we can pick that kind of stuff up before we get into the OR. The kind of classic adage of what's the fail to plan, it's the plan to fail.
Anything different, Chance, Stefano?
Intraoperative management of MCL disruption, primary total knee is a direct repair for me and a prolonged immobilization. If I have the polyethylene to constrain, I'll use it. If not, I won't. I will just leave it. Chronic MCL, but if the femoral component's available for a further constraint, definitely. With the chronic MCL disruption, that's an age-based thing. So if a younger patient, then I'll call my colleagues in sports medicine, have them do a reconstruction alongside with me. And if there is, and prolong them, but an older patient, I think a hinge is not an unreasonable option, as you did earlier.
Chance, anything different?
No, I agree with Stefano's comments. I've actually had this happen once intraoperatively, and thankfully only once, at least that I know of, and did a direct repair, prolonged immobilization. The patient actually did quite well, so I was pleasantly surprised by that, and I didn't change the level of constraint. I used a PS knee.
How do you do your direct repairs when you're doing them?
Yeah, so what I did was use a non-absorbable stitch, like a number 5 Ticron, so something that's very robust, and basically imbricate, sort of overly tighten down the MCL, not just directly end to end, but sort of like a pants over vest, have overlapping ends. And I did it through basically it was like a figure of 8 type stitch, but a couple extra passes, not like full crack out or anything, but it worked well, and thankfully that's one of those things you're glad when you notice it when it's happened and not after the fact, because that becomes a much harder thing to deal with, out of the OR. So.
Yeah, and I think, prevention's obviously the best treatment, making sure you have a retractor where your saw blade, and it's real easy for your PA to be daydreaming. You put a Z in there and they're looking someplace else, and suddenly, you got a Z on the medial side of the knee, but it's not where your saw is actually cutting. So I think being responsible to make sure the Z or whatever retractor you use medially is where your saw blade is will really help that. And the question of why nicked it, it's sort of like being pregnant, are or you aren't and off. I mean, you can nick it, but when you look at the MCL, it is a very thin ligament, and the width of it anterior posterior is pretty narrow, and if the blade gets out there, it's probably going to get it. But I think you're right. Repairing it is probably the best thing to do. And we all learn how to do the crack out suture, but then when you're suddenly doing it and you've disrupted the MCL, you're going, how did he pass that again? So it's a crack out-ish repair on each side with non-absorbable stuff. And actually, folks out of Rush published on this in 2016, and they had a 1.2% incidence of intraoperative MCL disruption. And with repair bracing, they had no episodes of instability post-op with both PS and cruciate retaining knees. So I think the key is number one, recognizing it. Number two, doing as good a repair as you can, and then protecting it. And the odds are it'll turn out pretty well. What makes it challenging is if you don't recognize it and then it goes on like this and you're dealing with it 6+ weeks down the road, that makes for a more difficult reconstruction for sure. Okay, so we're kind of escalating along here. This is 65-year-old female, BMI 38, left knee pain, having increasing pain, decreasing function, has failed conservative care, typical story, appropriate candidate for a knee replacement, has a little hypertension, type 2 diabetes, not shocking with that BMI. Knee exam, reasonable range of motion, has a valgus alignment but corrects to neutral, so soft tissue-wise doesn't seem to be real issue. Normal motor and sensory exam. Here's a pre-op x-rays, maybe a bit more valgus than the other one, but not an unreasonable candidate, having failed conservative care for a knee replacement. You guys agree? We're okay?
Yeah, I think I'd want to make sure this patient was really engaged. I mean, the BMI creeping up on 38 and the diabetes sort of doubling up on those risk factors. I think you want to make sure that you're as optimized as you can be.
So if her A1C was like 10, would that make you pause?
Yeah, that'd be a no-go for me.
Yeah. So do you guys have a hard cutoff for A1C?
It's, as a group, we've tried to come up with a number, and there's obviously a lot of varying literature about this. If I had like point-of-care fructosamine testing in my clinic, it might be a little bit easier, but that doesn't really exist. So, as a group, we've decided that 8 being sort of a proxy, although there's certainly literature that suggests that that's not necessarily the best proxy or a great proxy at all. Although I think in my mind, for me, having their diabetes well controlled, to me, is a proxy of their engagement in their own health care, as well as the fact that maybe it'll decrease the risk of infection, maybe not. But I would not operate on her with a hemoglobin A1C of 10.
Yeah, we've done the same thing. A1C of 8 seems to be a cutoff that people talk about. We try and enforce that unless you find out about it the day before. Then you go, well, probably okay.
Bill, let me just push back on that a little bit. So it's we looked 7 or 8 years ago now at the Kaiser Registry and looked at the impact of A1C and its correlation with outcomes, and we have a pretty darn good set of outcomes that and we could not correlate A1C with infection risk. The same time, Giori published his article out of the VA at Stanford and showed a strong correlation between A1C and infection risk. 2 or 3 years later, the data starts being more clear that as a perioperative glucose control with the CDC now, as it was on the early talks, suggesting 200 maximum in the first perioperative period being the actual thing that actually drives infection risk, not A1C. So with the caveat that A1C itself is is not an endpoint that really correlates to infection by itself, the question then becomes, is the A1C a better proximate for the patient's engagement in their own health? But within the diabetes literature now, there are certainly patients whose genetics simply won't allow consistent sugar control, and in some patients having A1C that's low is simply not, it's just a hard thing to attain, and they're going to be at high risk. So just keep that in mind. It's not as subtle as just a number, and that somehow if we keep them below 8, you eliminated diabetic risk. It's not that simple.
No, I would agree with that. I mean, it's a variable that we can measure, and I think it's indicative perhaps of overall health concerns. Certainly perioperative glucose variability, as we heard yesterday, is a big issue, and I got to admit, a few years ago when they started bringing that up, I went, what's the big deal? But I think it is a big deal. And again, it's one thing we can check, just like smoking, yes or no, we can check. And these are all things I think we're getting more dialed into, optimizing our patients, particularly when we're going to be responsible for their postoperative care with regard to complications and costs. So this patient had a left knee replacement, fixed bearing total knee, used a stem tibia just because the surgeon was aware of the data about higher failure rates in females with high BMI and smaller tibial size. Post-op day 1 apparently was in that study where you don't get up on the day of surgery. So post-op day 1, I was unable to bear weight due to pain, didn't pass physical therapy. And so they went, wow, okay, that's weird, but maybe she's just not that motivated. We'll send her to a nursing home. So 2-week post-op visit, comes in and can't bear weights, in an x-ray, and the surgeon's wondering what's going on, how come they're not meeting their rehab goals. Does anything about this trigger an alarm in you guys, i.e. can't bear weight the day of surgery or the day after surgery? Chance, how are you going to deal with that patient? Tell your PA, just go in and tell them to get going?
Yeah, I think there's a big difference between, it hurts when I walk, or I cannot bear weight on this leg. So that to me gets an immediate x-ray. If we get a call about that and it's out of the hospital, that's come into clinic and get a film. I think you have to assume the worst in this case when somebody truly can't bear weight. That being said, I've probably seen some patients who that was overstated over the phone, and then you got them into the office, and they say, oh, no, I'm actually doing okay.
Yeah.
But I think it's worth low risk to get an x-ray and bring that patient in.
Yeah, I think that's a great point. We've all had the nurse call you up and say, oh, they won't get up out of bed, or they're only walking to the bathroom. And there is a big difference between it really hurts, I don't want to do it, and I can't put weight on my leg. And so I think that's a key point. If you hear that, and you probably have to go see the patient, just confirm to yourself that that's really the case, I think that merits an x-ray, because that's odd. And we've all had the patient who's not super motivated. But so it comes into clinic 2 weeks, and they get an x-ray. Looks like this. So now what do you do? And the surgeon noted after the call to us, there may have been a crack. I kind of felt or heard something weird when I was hitting on the femoral component. So I guess if there's any question intraoperatively that something untoward may have happened, what do you do? How do you check this? Derek, have you ever had, of course, only when a resident was doing the case, but have you ever experienced anything like this?
Yeah, I mean, I've certainly cracked the femur intraoperatively on revision cases. I've become better at passing cables around the femur than I wished I had to be. But I think that, again, speaking of Chance's point, I think the onus is on us to prove that everything's okay before we assume that everything's just fine and the patient's just being a wuss. Because that's pretty sad and pretty horrible. I think that intraoperative fractures are going to happen, well studied in the literature. I think it's a complication that we don't really talk about that much, because I think often it goes either unrecognized, under-recognized, or it heals on its own without event. However, especially in a patient who has higher BMI and obviously relatively poor bone quality, this can be a significant issue. So, I think that if you fear, anytime you feel something or hear something or think about something that just doesn't feel great, just call the CR man, get an x-ray.
Yeah, and I think particularly with the PS knee where you're cutting a box out of the femur, if you don't remove enough bone, the saw skives or something, and you try and put on the trial, you can crack the medial femoral condyle, particularly if you look at a severe valgus knee. This one isn't severe. A lot of times that medial bone hasn't been loaded, and so severe valgus knees, you may even consider putting a short cemented stem on the femoral component, just because I've had this happen at about 8 weeks post-op. Patient tripped and fell and broke through the medial side and had a supracondylar fracture. So I think if you have poor bone quality, severe valgus, it's not unreasonable to consider cementing a short stem. Certainly, if anything seems to have happened in surgery, you want to bring in the C-arm and check it out and see what's going on. All right, so what do we do now? You get a call, hey, can I send this to you? I don't know what to do. I guess you could go, no, you can't send it to me. Apparently, we haven't learned that very well.
Yeah.
All right, so Chance, what are you going to do here now? So this person arrives in your clinic. You know, they're not bleeding or anything, but their legs kind of floppy. They can't bear weight. BMI 38. Doc, you got to fix me.
Yeah, I think at this point you're obligated to do something to get them ambulatory. 2 weeks is a suboptimal time because you're in your peak inflammatory phase. The wound is a colonized wound. I think you're not excited about reoperating through this wound, but so I think you have two options. One is you go back through the wound and you could, depending on the bone quality, you could revise the femur to you'd have to revise the entire construct, unfortunately, and you could do, a relatively quicker operation might be just doing the revising this to a distal femur, cutting out the fracture. Again, that's a salvage operation, but this patient's in rough shape. That, of course, is going to require revising that tibia, which is the long stem with the cement. So that's a long day, probably. The other option is going laterally and trying to fix this in some way. Although it looks like there's some comminution on the medial side, bone quality doesn't look great. So I think, unfortunately, in my hands, this would probably turn into a revision to a distal femur. I think that would be the most predictable outcome in my hands. But if I had a good traumatologist that was with me that felt like they could fix this well, I'd certainly have that discussion with them ahead of time before I bought it one way or the other.
Any more studies you'd get to see what the bone looked like on that distal femur?
Yeah, I think certainly something with some cross-sectional imaging, CT scan would give you perhaps an advantage in assessing that fixation. The medial side actually might be completely unstable. The fixation may be gone from that medial side on that component at this point. But I think a CT scan could offer you something, although with the metal artifact, it might be a little challenging to interpret.
At least gives you some time to think. So Derek, let's say you thought there was enough bone. Would you use a locking plate, a retrograde nail? How would you fix this if you thought you could?
So again, I agree with Chance. I don't think that this is actually fixable, but let's assume that it was fixable. So I especially in someone with poor bone quality, I think the results of retrograde nails are actually pretty poor. Our traumatologists have moved away from them for a vast majority of patients. Particularly in patients who are obese with poor bone quality. Additionally, with the box in this, you may not be able to pass a retrograde nail depending on whether or not that's an open box, and you may not be able to get your fixation distal enough. So I think if this were fixable, I think you would go with a long lateral locking plate, remembering that the strength of the construct is inversely proportional to its length. So I would actually do a long lateral locking plate. I'd take it all the way up to the vastus ridge, and even angle those proximal screws into the femoral neck if you could. Additionally, you may actually need to consider some kind of medial augment fixation. Now, plating the medial side of the femur is just not that much fun, but you might need to do that and do sort of a dual plating construct on something like this if it was fixable. But at the very minimum, a long lateral locking plate.
Okay. Yeah, I think those are good points. So kind of gone through that. Maybe if there's enough bone, you could fix it depending on how much the bone quality. People have talked about that if you have bone intact up to the level of the flange, then you could consider an IM nail. If it's not, probably a locking nail a locking plate would be a better option if you have adequate bone. And certainly if the bone just stinks, some sort of tumor-like prosthesis is going to be an option. Does it change your opinion when we reached in and the femoral component just came out like this?
Yeah.
So we kind of thought, maybe we're not going to be able to fix this. So, tibia stable, got that long cemented stem, trying to be proactive about countering the loosening in the obese individual. So unfortunately, she ended up with a tumor prosthesis. This is what was done, a cone with a cemented stem. I've also done these where I've just used a metaphyseal sleeve and cementless. I think they both work well. These are, on the one hand, they're not terribly hard. It kind of freaks you out a little bit. You literally just cut off the bone, make sure you protect the neurovascular bundle, and then it's just a matter of making sure your rotation on the femoral side is correct and making sure you get good fixation. I think you can do it with a cemented stem through a cone versus metaphyseal sleeves and cementless. They both work. Both are not super satisfying, and you worry about long-term outcomes with these kinds of procedures. Any
What are your,
comments?
Can I make a comment, which I really like? So these cones have a real tendency when you're seating them and splitting the femur longitudinally, and you have that cerclage cable to prevent that. But it looks like you did, after you seated it, you then took 2 further cables and tightened them around the proximal sleeve. And I think that is a really good idea because it ensures that you have a really snug fit around that cone, because it'll have a tendency to expand a little bit. I think that's really, really good idea. I've seen these go on to walk even with cement stems and then split. So,
yeah, that was treating my paranoia. And I think either one of these work. I mean, obviously with the cementless construct, you're relying on about 1.5 centimeters of bony fixation for the entire femur. With the one on the right, you have the cementless cone, but then you cement through it, which definitely gives you a longer fixation length. And so again, I don't know which one's right. Both of those are options. Neither one of them are terribly satisfying in the long run.
Bill, on a technical base, this device comes as a single unit. So how do you prevent the cement from, because you have a cement plug, from coming proximally and getting between the metal and the porous ingrowth and the bone?
Well, the cement plug proximally, you're right. And, you put obviously the cone in first, and all you can do is get it up against the bone, and there's going to be migration. But to the extent that you have good contact between the cancellous cone and bone, the cement won't get in there. It will get some of it, but you're relying on cementless fixation of the cone, cemented fixation of the stem.
Bill, do you have any tricks for judging your femoral rotation as being one of sort of the bugaboos of this procedure?
What I'll do is just put traction on the leg, kind of stretch everything out, kind of look and see where it looks like that should line up, make a mark with the bovie, and do that. That's probably the initial best bet with these. And again, this is something that becomes not an uncommon operation in the elderly individual that just pulverizes their femur distally, and rather than trying to reconstruct that, just going to a hinge like this makes what could be a very prolonged day a relatively short day. So she was toe touch weight bearing a couple weeks, extended the antibiotics a bit longer just because of the concerns about the contaminated wound. We kind of covered all that stuff. A couple articles that are interesting as I was putting this case together. This one is out of JOA in 2017. They looked at outcomes of surgical management of supracondylar periprosthetic fracture, found similar results with the retrograde IM nail and the locking plate, with the caveat that they used the nail in cases where they had better bone quality, and they used that cutoff if there's bone up to the proximal edge of the flange, and probably an IM nail's not unreasonable. Otherwise, the locking plate's reasonable. And then another article from 2016 looking at cases where they used a tumor-type prosthesis to treat supracondylar fractures. And then their third article, 2014 out of JOA, I mean, I'm sure we've all been there. We thought, well, we're going to do a retrograde nail, and you don't know how big the box is, or in some cases there's not a box. And I've had the misfortune of having to use the carbide burr to enlarge the box to get the smallest size retrograde nail in. So this article has the box dimension of every femoral component. So if you're thinking I might do a retrograde nail, you pull this up on your phone and it'll tell you how big the box is and what's the minimum size nail you can get in there. So that might be a useful resource for you. All right, third case, a 70-year-old female had a primary total knee done in an outside hospital, and during the operation, the surgeon recognized, and they weren't using a robot, that the patellar ligament was damaged by the saw, and they thought it was like a partial cut. So the surgeon did a primary repair with non-absorbable suture, I'm sure some modification of a Krakow stitch, and it seems stable to the surgeon, and kind of just let the patient go along, walking, and then 3 weeks post-op, the knee gave way, and the x-ray looks like this. So what do you do now? It's about 4 weeks post-op by the time this arrives at your doorstep. What do you see in the x-ray? Chance, what's going on here?
Yeah, I think this is a pretty classic patellar tendon avulsion or transection injury. You've got the patella alta that's very apparent. And then I think at this point you're obligated to, I imagine I would check a straight leg raise, but I imagine the patient is incapable of a straight leg raise.
Couldn't really do that.
Yeah. So I think you're obligated to perform some sort of a reconstruction at this point. There are multiple options for that. Allograft, the Mayo Group has popularized the Marlex mesh. You could consider another attempt at a primary repair, but that seems unlikely for success in this case, especially with the prior attempt. And then whatever you do, you're forced to do a long period of immobilization afterwards. So this is a challenging case. These are tough problems.
So Derek, any role for allograft reconstruction? That was popular 20 years ago, 10 years ago. Lots of long-term studies published about allograft reconstruction for extensor mechanism failure.
Yeah, I've honestly become a much bigger fan of the mesh than I have of the allograft. I think the mesh works pretty well. It's reliable. It's reproducible. You don't have to wait for the allograft. I don't know if there's a clear difference in infection rates. However, the allograft, I know the mesh has certainly put in some, a bunch of other stuff, but the allograft has just put in a ton of dead tissue right under the skin, and I just don't love that. So I've become much more of a mesh fan, and that seems to work reasonably well. But I think that one of the keys for it being successful is patient management of patient expectations in terms of both their ultimate expectations and the recovery period. And then also, if you have the opportunity, and this doesn't come to you chronically, if this came to you at 4 weeks, like you said, to get to it sooner rather than later. Because that patella will get stuck up there, and no matter how hard you work, you're not going to get the quad to excurd very far if it gets chronically scarred in.
Stefano, you probably, like me, did not a lot, but did allograft extensor mechanism reconstructions, thought they looked really good and kind of protected them, and then you see them back at 2 years and they have big lag and not a whole lot better off than when we started.
Right. So then I went from that to using cadaver tibial tendon reconstruction that I kind of would do a drill hole in the proximal tibia, loop it into the patella, loop it back to itself, and then do a reconstruction that way. That worked better than the allograft. And then when the Mayo Clinic came out with their idea of the mesh, I started going that direction, and I haven't really looked back. It's been reasonably successful, about 10-degree lag, maybe 90-degree flexion, 100 is reproducible.
So how would you, let's say, it sounds like everybody's agreeing that maybe the Marlex mesh is the best way to go. How do you manage this person post-op? So you tension it well, you do a good job, everything, you're happy. How are you going to manage that patient post-op?
Cast, minimum of 3 months, full leg.
Okay.
No ifs, ands, or buts. If they won't agree to that, I won't do it.
Okay. Stefano, anything different?
No, and actually cast as well, but I've just been managing these patients with the conical leg. They sit in a wheelchair, and the posterior edge of the cast creates a wound that needs to be, it always happens, it's very difficult, it has to be addressed, you can't ignore it, expect it, ask to be told about it, it's a problem. If it's a long, thin leg, it's usually not an issue, and it's about 3 months.
Yeah, I think that's the key, is a prolonged immobilization. So this is what the stump looked like. It kind of like you just got some Dungeness crab and stuck it in on the proximal tibia and said, well, that used to be the patellar ligament. So
That's not the first thing that came to mind when I saw that picture, but that's interesting.
I'm
Thank
from
you
the
for
Pacific
lunch. Thank you for
Northwest.
that.
It's like perfectly cooked crab. And so how do you fix this? I think we kind of went through that. And again, our Derek of our group, our younger partner who gets a lot of this stuff, has done a number of these, and it's worked very well. This was Arlen's article out of JBJS in 2011, going through the technique. And I think the key is getting fixation in the tibia. If you're not going to revise the implants, as in this case they were not revised, you can create a trough and put a screw, cement that in, and fix it to the tibia. If you're doing a full revision, you can incorporate it into your tibial fixation. But as the panel has alluded to, you want to get proper tensioning, make sure you cover the marlex with soft tissue, and then prolonged immobilization to allow this to scar down and maintain some extensor function. And of all the options for a really bad problem, this seems to work the best compared to everything else we've done.
Bill, I'll just make one more comment in terms of another technical trick that it's at least been helpful to me. I think a key part of the success of this operation is also they talk about the VMO advancement. So you end up kind of making a sandwich of the mesh. You have the quad underneath the mesh, then you have the mesh, and then you try and imbricate pants over vest technique, the VMO over that. And I think that's a really important part. The ones that I've done where I've been able to successfully do that well have outperformed the ones where I have not been able to bring the VMO over, either for soft tissue tension reasons or poor skin. But I think that's a very important part of this. And then the other thing, and they show it here in this picture, they try and create a little pocket. You leave some of that scar tissue behind the patellar tendon intact, so you can pass that mesh with a little bit of a soft tissue sleeve between it and the prosthesis, so you don't have the mesh rubbing right on the tibial tray, which can also lead to failure and fatigue of that. So I think those are just a couple little things that have helped me make this a more successful operation. But yeah, this has actually worked quite well. When I first tried it, I was dubious, but and the Mayo Group has now published, I think, subsequent follow-up showing good results even at multiple years out. So.
I think the other key, and this is another just a landmine to avoid, is that when you ask for the mesh, you have to ask for the older untreated mesh. The newer meshes all have a coating on them that actually prevents sort of the scar tissue formation that we're looking for here. So you have to ask for the older mesh.
Right, good point. Well, all right, we're a few minutes early. I think in the sake of getting back on time, we'll stop this panel. Thanks very much. Hopefully we don't encounter these complications very often.